Hello, my name's David Armstrong, and I'm the Director of the Health Workforce Tactical Assistance Center. And today's webinar is entitled Findings from a Scope and Review of Dental Therapy Research. For those of you who are not aware, we are HWTAC, that is the Health Workforce Tactical Assistance Center. We're based at the Center for Health Workforce Studies at the College of Integrated Health Sciences at the University of Albany, State University of New York. And we are one of 9 federally funded health workforce research centers located around the country. And each year we go ahead and do a number of initiatives designed to provide assistance to states and organizations on health workforce data collection, analysis, and dissemination. And with that said, let me go ahead and introduce you to today's guest moderator. Today we're joined by Jean Moore, the director of the Center for Health Workforce Studies at the College of Integrated Health Sciences. Jean, would you like to introduce Beth?
Absolutely. Thanks, Dave. Hello, everyone. So today's webinar is based on a scoping review that assessed the current evidence base for dental therapy in the U.S. and to identify gaps in the available knowledge regarding its implementation, safety, quality, economic impact, and contribution to access to care. The research team for this study was led by Beth Mertz, and Dr. Mertz is today's presenter, and she is a member of the research faculty at University of California at San Francisco, where she's worked since 1997. She has a joint appointment with the School of Dentistry and School of Nursing. She is an internationally recognized expert on a broad range of oral health professions, workforce policy, and analysis issues. And for the last 12 years, she has collaborated with our Center for Health Workforce Studies, and has served as a co-PI for the Oral Health Workforce Research Center. Take it away, Beth.
Thanks, everyone, for coming today. As Jean said, I will be walking through the findings from our scoping review. So I'm going to give just a quick introduction to some context for our study, and then I'll walk through the specific methodology we used for the scoping review and the thematic findings that we have related to the evidence on dental therapy specific to the U.S. context. For those of you not acutely aware, the dental workforce in the United States, we have sort of long-standing issues with supply and distribution, and specifically a shortage of minoritized providers that is extremely persistent, specifically Black, American Indian, and Hispanic providers, although some Asian subgroups as well. An ongoing geographic maldistribution, concentration in urban areas, lack of providers in rural or frontier areas, and really not a whole lot of change to the occupational hierarchy over the last century. Even though we have seen some changes with hygienists doing public health practice or expanded function dental assisting, we, for the most part, we still have our dentists, our hygienists, and our assistants, and not a whole lot of other types of providers. The COVID pandemic did a lot of damage to the health workforce broadly, but in the dental workforce specifically, we saw a large exodus of assistants and hygienists, and the recovery from the supply of those providers has been slow. And then the training pipelines have been really expensive, and there's a real disconnect with trying to get folks through into practice. And the lack of faculty and clinical training sites. So overall, there's a lot of work that needs to be done broadly in workforce supply and distribution, and there's a lot of opportunity to expand and change some of the models that we've used in the past. At the same time, underserved patients, specifically our Medicaid and Medicare enrolled populations, still have very difficult access to care. The systems of care and coverage are really quite, you've sort of got a private system with private dentists and private insurance or self-pay, and then a public system that's much smaller and serves the Medicaid population. And as well, Medicare does not cover basic dental services. So that's a huge problem as well. And even though this is really start changing, and we've seen a lot of changes in this recently, the majority of dental services are still provided in a small business practice model, which really doesn't allow for workforce differentiation and moving to scale with the types of workforce innovations that we've seen in the rest of healthcare with providers at multiple different levels and having overlapping scopes of practice to allow for flexibility in local labor markets. And then I did touch on this a bit, but the really oral health is sort of the last frontier where we don't have parity related to our policy environment. So there's no universal coverage. Medicare doesn't cover dental. Medicaid does not require dental coverage for adults. And we still have a large uninsured population in addition. And so there's really sort of this gap of allowing access to care as part of the overall social contract. So this is the backdrop to the study. So we've got this a large set of sort of structural problems but changes are coming and need to come because of the pressures in the environment. And so this is the context for bringing in dental therapy. So just a little bit of a timeline, and I'm not going to go over all of this information. There's a ton of details at the website that is at the bottom of the page, dentaltherapy.org. So just about anything you'd ever want to know about dental therapy. But in the context for our study, 2005 was when dental health aid therapists began practicing in the Alaska Native Tribal Health Consortium after being trained in New Zealand. And 2009 was when the Minnesota passed state level dental therapy legislation. So those were sort of the first two contexts, one in a tribal context, one in a state context, where dental therapy was brought to the United States. Has been practiced around the world in 60 plus countries for over 100 years, but our context is bringing it really to the US. A couple of key things were that CODA, which is Commission on Dental Accreditation, approved guidelines for the dental therapy programs in 2015. And that sort of really helped standardize some of the education approaches. And then over the next number of years, you started to see additional states passing laws, starting education programs, and authorizing the practice of dental therapy, both in tribal settings as well as in state settings, and oftentimes both. So our study, our literature goes through mid 2025. So we've got about 20 years of research that we looked at for our scoping review. This is another infographic. This is on our website for the Oral Health Workforce Research Center. We have a couple other ones as well for for hygienists, as well as some specific things like silver diamine fluoride. But this shows you for all of the different states whether or not there's a campaign. So that is, there's an active group of advocates that is trying to bring dental therapy to those states. So that's in the purple on the outside. And then it goes all the way down to the most inner circle where the red is are there dental therapists practicing in the state? This is fluid, so this was updated recently, but it may not be exactly correct, just given the speed at which therapists are being trained and going out into practice. But in terms of the states, there are 14 states that have authorized dental therapy in one form or another, either through tribal or statewide. Generally speaking, dental therapists, they work for a dentist. They are employed by a dental office and by a dentist. They're not independent providers. The scope of practice is generally the same. It depends really on what the state laws end up being. And most states do have restrictions on scope of practice, either by a setting, say, for example, must work in a federally qualified health center, or with a population that they must serve a certain percent of the population that's Medicaid, or work in a tribal community. And in those settings, they're always overseen either directly or indirectly, or they can work under general supervision by dentists. They might go out to a secondary site once the dentist is comfortable with their scope or with their practice, and they can go see folks, say, for example, in mobile vans or in auxiliary sites. So you can check that website for updates. So now that's just the context. I'm going to jump into the purpose. So there is a lot of literature on the U.S. adoption, and we started to see more and more research coming out, but we really hadn't done a summative literature review. And so what a scoping review is we systematically assess the research for the type of research that's being done and the quality of the evidence that's being produced. So this is an assessment of the research, not an assessment of dental therapy practice itself. The research does that, but we are assessing the research. So this is important because resistance to adopting dental therapy is often predicated on myths and misinformation. Lots of statements that the occupation is unsafe, that it's low quality or somehow harmful to patients or lacks patient acceptability. Again, this is myths and misinformation, and so we wanted to assess the evidence of what's really going on and provide that so that policy could be informed on appropriate evidence. And like I said, our work went from 2005 to 2025. So a scope and review follows a very systematic approach to mapping evidence onto specific topics, and it identifies main concepts, theories, sources, and knowledge gaps. So unlike a systematic review, which is always looking at research on the same exact topic, it's a higher level of rigor and evidence. The scoping review, we use this when the evidence might be quite varied. So we don't have 10 or 15 clinical trials on the same exact topic, but a whole wide array, which is where we are in the dental therapy. And for most workforce type studies, we just don't, it's very rare to see a systematic review on something around a workforce specific innovation. So we did a literature review where we looked at peer-reviewed and gray literature. There's a screening step, a full text review, and then we do a structured data abstraction and quality assessment. And we used the online platform Covidence to conduct our review. We ultimately found 124 articles that were included into the review. So the inclusion criteria were that the study had to be on dental therapy, it had to be original research, it could include descriptive studies, and it had to be based in the US. We excluded anything that was an opinion piece, a letter to the editor, or was an international study outside of the United States. Just because of the language that was used early on in dental therapy, we also used search terms around advanced dental hygiene practice or dental nurses. There were a number of other terms that have been adopted from international literature that we used in our search because just to make sure that we were capturing everything that was done in the US context. So there are 3 study questions. What's the current evidence base? What is the available evidence base, and how has research been conducted? And then where are there gaps in available knowledge on dental therapists? So we used two quality assessment tools. So after we found the literature that met our inclusion criteria, we abstracted what the type of study, and then we wanted to give the study essentially a grade to say whether or not there were no concerns around the quality of the study, whether there were minor concerns, moderate concerns, or serious concerns. And because so much of the early research was descriptive, we needed to include something that could evaluate purely descriptive studies. So there's this weird tool, ways of evaluating important and relevant data, that we used exclusively for the descriptive studies. And then this includes a set of sort of questions to respond to in a final grading system that I just explained. And then we use the MetaCat tool that is designed to be both generic and specific. And we use this to assess studies that did not fall under the weird tool criteria. So these would be randomized studies, non-randomized studies, cohort, case control, observational, primary qualitative studies, those more analytic studies. And then what we did is we adapted the weird tool grading system for final assessment. So when I present the results, you'll see which tool was used to assess the studies, and then the actual assessments were paired together. So in our search, we this is basically our flow chart of getting to the 124 studies. There were 1,760 records that were identified. 1,321 were unique. We reviewed 305 full text articles, and then ended up including 124 studies. So I'm going to give you a broad overview of the way that we present the evidence, and then I'm going to repeat this as we go through each one of the themes. So the first chart is the publication year. So you can see from 2005 through 2025. So that was the number of publications per year that were included. And then the study location, so this varied. So really, Alaska and Minnesota are going to have the most studies because those were the initial adopters. They have therapists practicing there for the longest amount of time, allowing for more rigorous studies over time. And then there are other states such as Oregon, Washington, and Idaho. There were some studies that were done sort of in the region. And then there were a number of studies that were sort of national or in another site, specifically when they were doing sort of like acceptability studies, maybe doing a survey of dentists, for example. It might be national. So for each one of the subcategories, you can see the locations of the studies as well. One of the key things that we do in a scoping review is that we come up with the themes of the research. So the primary topic of each one of the studies was categorized into one of these 8 buckets. So this was acceptance of dental therapy, the care delivery system impact, cultural competence and diversity, sort of economics and the finance, education and training, health outcomes, quality of care, and then scope of practice. And then overall, again, this is for the 124 studies. We found that there were about a quarter had some minor concerns. And again, this is an assessment of the quality of the study itself. This is not an assessment of dental therapy. It's an assessment of the rigor and the quality of the study. So there were very few with moderate or serious concerns. And then the majority, over 50%, had no concerns or very minor concerns. And so the orange bar is using the MetaCat tool and the yellow bar is using the weird tool. So you can see that overall, they're either the body of research that we're looking at was either had very minor or no concerns in terms of the quality, with just a few that seem to have some broader issues. I will say in the assessment of the quality, the biggest issue that we saw in the quality of the studies was actually not having human subjects protections described in the research assessment and evidence. That's actually a very important thing. And a lot of these studies were done by community organizations or state agencies that really don't require human subjects review. And so that's actually the thing that drove most of the concerns. Not that human subjects were harmed in any way, but that it was not described or included in the research. And the second thing is that there were no theoretical models that guided the work. So when we talk about why things had a moderate or a serious concern, it was those two issues that really drove most of the lower scores that we saw in the overall quality. So for the next few slides, I'm going to go through each one of the individual topics. So the first one I'm going to cover is education. There were a number of studies about implementing education, dental therapy education across the sites that approved dental therapy. And you can see on the right, I'm not going to go over this for every single bar, but you can see where the study location was, the publication year, and then the quality assessment. And I'm not sure why it's not exactly the serious. It starts with serious and then goes to no, moderate, and then minor. So they're not exactly in the order that they should be, but hopefully I know that they're correct. I don't know why it got moved around that way. Sorry, I didn't catch that. But so for the models of education, a lot of the early articles focused on describing what dental therapy education should be, because it was really being adapted from New Zealand, and they were trying to figure out, well, what would that look like in the US context? There were also articles talking about how dental therapy should be regulated, although as the dental therapy was adopted over more states, and especially after CODA came up with accreditation guidelines for dental therapy programs, we really stopped seeing some of these like more descriptive studies, and have moved more into like, well, what's the implementation been? As well in education, there were early sort of program stakeholders, sort of attitudes of faculty to bringing these in to their education program, as well as to other students. I think at this point, we have a set of relatively mature dental therapy education programs. We have standards for those education programs. We have models to be adopted by new education programs. For example, Northwestern Technical College that just opened the newest dental therapy education program in Wisconsin was able to get up and running extremely quickly because of all of the resources that the early adopters had put in place. And I'm not sure how much additional research we're going to see about the education itself, but that the gaps that we sort of saw within this education area were that there wasn't a lot of broad information around the characteristics and qualifications of dental therapy applicants and enrollees. So for example, the American Dental Association, Dental Hygiene Association, some of the others, you can kind of get year-over-year data on, the number of students per program and their demographics and how long they're taking to finish and various things like that. So you can get some general workforce data. So that is still missing. And there's not a whole lot of in fact, there was nothing that was included in our study. I've seen some presentations on it, but not formal literature on the financial impact of dental therapy education, such as educational debt and income potential. Not that this hasn't been discussed and studied, or is not documented somewhere, but it did not come up in our inclusion criteria of formal publications. The next area that we looked at is the area of acceptance of dental therapy. And in this particular arena, there was a lot of early literature that sort of was surveying dentists about whether they wanted to see dental therapy come to the US. Dentists, unsurprisingly, were the group most resistant to the concept. And what we have seen is that as dental therapy becomes more widely understood, and as dental therapists actually, as dentists have actual experience with dental therapists, where it moves from being hypothetical to something that they've actually experienced, that resistance dissipates. Oops, sorry. Survey of other groups are also included here. And then there have been surveys of dental hygienists asking if they would like to become dental therapists or pursue dental therapy training in the future. And so this is all sort of kind of looking at attitudes around dental therapy. I think the gaps in this work, one of the areas around the acceptance that we could see some more information, there's a little bit, was really patient satisfaction. And then also understanding the process of acceptance into care delivery teams. We're bringing a new member of the team in and what that process might look like. And then yeah, as adoption continues to expand and increase, I think those are some of the things that we've seen in the broader workforce literature that we don't see yet in the dental therapy literature. For scope of practice, the literature here was primarily descriptive, with the exception of one mixed methods study. And similar to what we saw with the acceptance, a lot of the really early literature was sort of like what it should be, where later on you start to see, okay, now we can actually document what it is. And what we really don't see, the gaps that we don't see yet, are kind of comparisons between states that might have slightly different scopes of practice or different, it's not so much scope of practice varies as much as setting restrictions and some of those other things. So for example, states have not been consistent in prerequisite training requirements. Some states require master's degrees. CODA does not require a master's degree. The newer and the more agreed upon type of program really is a three-year program post high school. Supervision tends to be kind of one of those things that changes over time because they work directly for a dentist. The dentist might want to do direct supervision at the beginning and they get more comfortable working with the dental therapist, be able to go to more general supervision. The really big problem we see on the scope of practice, and something that I think we may need some future research on, is this issue of inhibiting license portability. So if you have a state that requires a degree level, a baccalaureate degree, a master's degree, but you have individuals who've graduated from an accredited program and are practicing in one state, but they don't have that degree level because it wasn't required and isn't really necessary for actually practicing at that level, this is going to cause interstate movement problems. I think most of the states that have now passed authorization for dental therapy require licensure from a CODA accredited program, which shouldn't inhibit licensure portability, but some of the other things like requirements of being a hygienist first, or like I said, a degree. So those would be things that would be ripe for study going forward. The care delivery system impact. This is a big bucket. There were, I think, 22 study. Yeah, 2012 was 22 studies. And this had a good portion of our peer review articles, more than, say, gray literature or other types of reports. Most of the studies were looking either at successful practices in single sites. So they might have gone into something, for example, Apple Tree Dental in Minnesota or Children's Dental Services and done sort of a case study of the implementation in that setting. The state of Minnesota did some annual updates on the profession using licensed and survey data, but again, descriptive. And then early on, again, there were some hypothetical modeling studies about how practices could incorporate dental therapists into delivery systems. But later on, we were able, once that was actually happening and there was enough folks out and working, we're able to see that, particularly in Alaska and Minnesota, where dental therapists have been working the longest. So some of the more robust studies by Dr. Chi and Dr. Alani have shown really positive impact on both access to care and health outcomes in populations that are served by dental therapists. And there was even a newer study. It's not included because it hasn't been published yet, but it was presented at a recent conference by Sukhaisky, who showed that showed a significant decrease in emergency department utilization in counties where dental therapists were practicing. So we look forward to including that in future iterations of our review. Because these studies were the bigger using claims data and more impactful types of studies, we did see a little bit more that had moderate or minor concerns. Again, these were with study quality and usually had to do with lack, in these ones particularly, and with the dental literature broadly, rare to see lack of theoretical frameworks being used in the studies. The economics here, the majority of these studies are also evaluations of single sites. And I think this is an area where there is definitely a lot of gaps that could be filled going forward about how to showcase both the financial and economic impact of bringing in dental therapists. There have been a couple of the big themes we saw across these were that dental therapists certainly increase productivity and profit for the setting in which they're employed. This was shown both in the single case studies as well as some of the more system level analyses that are more recent. And we did see sort of task shifting. So dental therapists increased dentist availability for higher level, more complicated procedures and high skilled procedures. And so, for example, a study using Apple Tree Dental data by my colleagues here at the Workforce Center was able to show over time that as they brought dental therapists in, you started to see the dental therapists doing more of the basic restorative procedures and dental therapists or dentists increasing their capacity to take care of patients who needed more complex care. And particularly in Minnesota, but also in Alaska, there have been studies showing that dental therapists increase the Medicaid utilization. So from sort of a system economics versus an individual clinic or practice economics, we see that at the system level. And again, those requirements for having a practice see Medicaid patients are obviously going to contribute to this, but also having just more providers out there in the Medicaid space is hugely needed across the country. And see, I've got two more. So cultural competence and diversity. The themes here really included enhancing diversity of the dental workforce, which is sort of a consistent problem. The the importance of tribal representation and reinforcement of tribal sovereignty as a critical component of the advancement of dental therapy in tribal settings specifically. That has been hugely important due to the positive effect of cultural competence on patient trust and outcomes. So, again, going back to my earlier comment about the fact that we don't have sort of widespread tracking of, race, gender, background, training site, et cetera, as folks go out into practice. I think as the field evolves, we will certainly the American Dental Therapists Association may take that up. That's generally what the American Dental Association and others do as far as being able to say what the workforce looks like and how it's adapting and changing over time. There were a lot of the studies in this, the descriptive studies here were, a lot of those were qualitative as well, and sort of getting the personal experiences of patients and other providers in working with dental therapists. For health outcomes, these are mostly descriptive studies because studying health outcomes takes a long time if you really want to look at it at the population level. So what we saw here were two main themes, including kind of quality of treatment provided by dental therapists and the supply of treatment provided by a dental therapist. So the quantitative results found that dental therapists had an effect on the increase in the total number of procedures, and preventive services were a larger share of total procedures, particularly for mobile sites. Several studies that had high evidence ratings demonstrate positive outcomes in Alaska. And in addition, multiple studies employing mixed methods or retrospective observational study designs demonstrate that positive outcomes as a result of dental therapists in the workforce. Again, such things as improving access to care, increase the number of dental visits, reduction in, say, having to have extractions of the front teeth. There are a few other ones as well. But the overall initial health outcome data is very positive. And in terms of the clinical piece, this goes way back to the very beginning when they were first implementing it, really wanting to, assess whether you could train a dental therapist to provide equivalent care to what a dentist provides. And the research there is that it's consistent with the standard of care provided by the dentist and that graduating dental students and in fact, in the Minnesota training program at the University of Minnesota, they're literally trained in the exact same program with the same assessments and everything. So it really is equivalent. Okay, last theme is quality of care. And so a lot of these were from the gray literature, from pilot projects, sort of technical performance. Again, this is like even more technical, like looking at the, drilling or various procedure level assessments. As I said, clinical performance was on par. The quality of this research was good overall. And just one thing to add, the final thing here is that we did include within this group was that patient experience and patient satisfaction, those are important components of quality. And even though we did assess that also as part of our cultural competence piece, we did include that here too as part of quality of care, because the qualitative assessments really showed that patients were very satisfied with the care that they were receiving. So to conclude, there has been a significant body of research. So a total of 124 publications met our inclusion criteria. Um, and all of it is generally positive. Again, I'll remind you that our quality assessment was the quality of the research itself, not the quality of dental therapists. The research was overwhelmingly positive, and had a strong uh, as a whole, we're able to really say that it looks to be a very strong impact on health equity in places where dental therapy has brought into the state or the communities. Our studies clustered into 8 domains, which were acceptability, care delivery, system impact, cultural competence and diversity, economic impact, education and training, health outcomes, quality of care, and scope of practice. To date, most studies are descriptive or cross-sectional and focus on areas where dental therapy has been incorporated the longest. So this would be Alaska, Minnesota, and increasingly the Pacific Northwest, Oregon, Washington. The evidence that we found consistently demonstrated high patient satisfaction, increased productivity, expanded access to care, and positive or equivalent clinical outcomes compared with dentists for procedures that are within their scope. There were no empirical studies that identified patient harm or negative safety outcomes that are attributable to dental therapists practicing within their authorized scope of practice. There certainly were some gaps in the area in each of the topical areas. I've highlighted some of those. Some of these things may just take time. For example, comparing different educational models or comparing practice in states with different requirements. You're going to need a greater number of people to be out and practicing to start to fill those gaps. I think the delivery system impact is probably the economic research, maybe stymied by whether those health systems are willing to open up sort of their data to providing researchers access to patient and system level data. Although we know from the Minnesota experience that they can't produce dental therapists fast enough. The systems all want them. So from just a plain supply and demand perspective, we would seem to think that this is having a very positive effect. But large health systems may not want to, reveal their internal economics. And then in terms of quality of care, overarching that, well, the whole dental field has a problem studying quality of care, for example, because we don't regularly incorporate diagnostic codes into our claims and other issues with measurement and access to data at broader system levels. So I think the dental therapy, the studying this further in the space of dental therapy is going to hit those same exact problems. It's not specific to dental therapy. It's really specific to the overall field. So I will just say thank you to our partners. My colleagues, Aubrey Kotick and Miranda Wirtz, did the vast majority of the heavy lifting on this. Donald Chi, Margie Landelier, Jean, and Carl Self all were faculty partners and helped us with the themes and identifying literature. And of course, our funders, both HRSA through the Workforce Center and the Arcora Foundation that provided funding to make this possible. And that's it. Thanks, Jean.
Great. Thank you, Beth. So any of you have questions, please feel free to write it in and I can share it. Beth, I have a question that I'd like to ask, and that is, what are some of the key challenges to developing dental therapy education programs? One of the things that really struck me in some of the work that we've done is that there are states that authorize dental therapy and then couldn't get a dental therapy education program off the ground. Again, it seems a bit unusual?
Yeah, I mean, some of it is going to be political and some of it's going to be logistics, right? So I think in some states where the campaign has included um, the education programs from the start and maybe has identified education programs that are willing to sort of take this on and get it up and running versus passing the law first and then trying to find a dental education program afterwards. I think politically, we've seen dental schools, with the exception of the University of Minnesota, we've seen dental schools treat incorporating dental therapy programs as, sort of a third rail with their alumni, threatening to take money away from the school and all sorts of things. This is why the initial dental therapy program at the University of Washington was actually in the PA program, not in the School of Dentistry. But we've seen that in a lot of other states where the not just organized dentistry, but the dental schools in the states have been very hostile. So I think the most appropriate place and what we've really seen be able to work quickly and effectively is through the community college systems. Illisavik College is a tribal college. Skagit is community college. Northwestern Tech is a community college. Identifying a place that already has perhaps like a dental assisting or a dental hygiene program, or maybe even not, but then has a clinical partner where they can do their community-based education. I think we're seeing them be able to come on more quickly. The states that passed laws a long time ago, back in 2014, 2016, or states that require a prerequisite of dental hygiene, we've seen those states really struggle because the state laws added unnecessary steps to the process, which actually makes getting the education program up and running more difficult. So, as those states see other states that have been able to do it more seamlessly and effectively, perhaps they will decide to modify those requirements, both so that they can um, uh, recruit dental therapists into their state and produce dental therapists from their local population as part of their economic development and health workforce strategies.
Thank you. Um, One thing that I've observed, and actually when I was working with you in the scoping review, it became pretty evident that organized dentistry appears to be a group that is extremely resistant to recognizing the dental therapy profession. What do you think is behind that?
Yeah, I mean, I think it's historical precedent for a lot of it. I mean, we still see the physicians fighting with nurse practitioners, and the technicians trying to come into the workforce, and the psychiatrists and the MFT. So I think this is sort of inherent. We have this very hierarchical 19th century model for licensing and regulation of occupations and professions, one that really hasn't evolved to take into account the sort of flexible, dynamic workforce that we currently need. And because there's a lot of money involved, folks dig their heels in, and sort of the status quo is always what the professions are going to go for. I think it is changing. I think health systems and legislatures, they really don't have a lot of tolerance for all of the scope of practice battles, and they really just want a workforce that is competently trained and can effectively take care of the health needs of the population. So I think that the resistance has gotten quieter over time. Certainly, we still see state and national organizations coming out against this. But there's not really a lot of evidence that they can use anymore to say that it's problematic. Given what I've just presented, you can see that the evidence is positive pretty much across the board. And so, and really, I think the, you know, as more states and systems adopt dental therapists and as more dentists start to work with dental therapists, I also think that the tone and the resistance will continue to change. Even though you still see the medical associations fighting with the nursing associations, kind of at the lobbying, structural level, you'd be hard pressed to go into any health system anywhere and find not find doctors and nurse practitioners working together. That it's almost unheard of at this point. So I think that is the that's where there's an adoption and a implementation piece that I think has to happen. And I think we really need patient voices, right? I mean, dental care is the hardest and most expensive out-of-pocket service for people to provide or to get in our country. And if this is a step that states can take to improve access to care and help us, close that enormous gap in health equity that we have in oral health, that should really be the primary driver of adoption innovations, not sort of historic turf battles that are overlaid on many layers of gender and race and other historical structural discrimination. So you got to unpack all of that and really think about what kind of system you want to have in the future.
Thank you. Question from the audience. Will this be published as a paper? And I suppose the
Yes,
other question would be,
yes, it will. Very soon. Yes.
Okay, next question. Are there any studies related to whether BA RDH requirements result in graduates who are superior in any way to CODA accredited community college graduates with an associate's degree in dental therapy?
No.
And the no is that there aren't any studies.
There are no studies. Yeah, no, I don't believe there are there's the one program in Minnesota that is essentially an advanced standing program for dental hygienists. And then the other program has dental hygiene and dental therapy separately, but then they've sort of combined them. But that's not a requirement of the law. So I think you could, I mean, we've seen studies similar to this in nursing, which has a high level of differentiation in terms of entry to practice. So you can have an associate's degree, you can have a bachelor's degree, you can go straight to a master's degree, and in all those cases, you'd still be a RN. Or with the master's, maybe you'd be on a path to being an NP, but there have been studies that have looked at the differentiation in various quality measures. However, none of those have really resulted in a drastic change in the number of different entryways to nursing practice, because nursing is in such high demand. So if you shut down all our degree programs, you wouldn't have any nurses. So it also provides people career ladders. I think that's one of the interesting things about this, is whether you start as an unlicensed dental assistant or a dental assistant or a hygienist, or start as a dental therapist and then want to go to dentistry, or as you add in these different matrix layers, in any case, if you already have done prerequisites, because if you've gotten one licensure, you're going to get advanced standing when you go in, if you want to have a career ladder and go to the next level or the next level. So But no, there's simply, I mean, those studies that have been done in nursing are on, the nursing is the largest health workforce in the country. So there's, thousands and thousands of people to study versus what we're talking about here would be, dozens at most. So, yeah.
Yeah, thank you. Next question. Does the scope of practice include serving those with disabilities?
That would be so I don't think that any dental or dental hygiene programs have serving individuals with disability specifically as like a legal scope of practice. That's more of a competency issue in terms of does the practice serve those individuals, or does the organization that they're working for serve those individuals? And then would they have, the specific training either through continuing education or, their initial training to do that? I mean, even the dental school doesn't require that specifically for as a competency. Usually you get that type of training in, say, for example, a general practice residency later. So I think that that would be, again, where whoever is working in the practice is going to be employed by the dentist, who would, I would assume, have that type of expertise, and then would ensure that the staff and the individuals working within that clinical setting are appropriately trained to take care of the patients that they're serving.
The Minnesota statute governing dental therapists talked about the therapists being required to have half their caseload be drawn from underserved communities, and I think populations. And I believe that the method behind that madness was recognizing that a requirement like that would increase the likelihood of dental therapists moving into working for safety net providers. But I honestly don't know the extent to which that is actually monitored. That's happening. As I understand it, dentists in Minnesota are becoming increasingly interested in dental therapists and recruiting them for private practice. So I don't know how that is playing out or how successful it's been.
I don't know the percent in the statute off the top of my head. I thought it was 30% of the practice had to be Medicaid,
Oh, okay.
versus 30% of the dental therapist patients. I'm not exactly sure. Obviously, that's somebody could Google that and figure that out. But again, this is where when you have a practice and you add a practitioner into the practice and you increase the capacity of the overall practice. And this is what a lot of the early sort of economic hypothetical modeling is sort of bringing in a dental therapist and looking at, we look at Medicaid billing data, something around 2/3 of services that are regularly billed through Medicaid are services that a dental therapist can provide. And so by bringing in a dental therapist and having them, you really can open up the overall practice to seeing Medicaid patients without the negative economic impacts if you were to do that, say, with an associate dentist, or just try to have the dentist who is working there already do it. So it's really a scale issue, I think, and being able to have some flexibility within the types of providers, regardless of whether they're dental assistants or dental hygienists or folks with expanded practice, and then a couple dental therapists, and then, I mean, even a brand new associate dentist that just finished dental school is not going to be doing what a seasoned 20-year veteran dentist is going to be doing, right? So you've got to sort of have that practice working that out as they go forward. But from a payer mix, the evidence that we've seen in the literature and that I've heard through presentations and so forth is that it's that overall payer mix is really the what they're looking for. So even if you're a rural dentist in Minnesota, if you bring a dental therapist on, you're going to be seeing Medicaid patients if if you're working in a rural community. It's really going to expand your capacity to do that. Yeah.
We are out of time, but I just want you to close up with one last question. Where is dental therapy not currently adopted, but would have excellent prospects?
Yeah, this is a great question. Thanks for asking. If you go back to the um, little wheel slide there, you'll see there's a whole area, the American South, that pretty much doesn't have dental therapy. And this is also the place that has the most restrictive scope of practice for both dental assistants and dental hygienists as well. And I think that there are huge opportunities particularly in Black communities, in Hispanic communities, where you have health systems that are oriented around those communities, being able to serve their specific needs, and where you have huge gaps in so really being able to do education to provide economic opportunity for individuals coming out of high school from those minoritized communities, then serve their own communities and to help enhance the oral health systems within those communities. We've seen it work extremely well in tribal communities, and it will continue to do so. But I think with some of the other racial ethnic minority groups, and then also in urban city centers for the same reason. So I think that could be extremely adaptable and really a wonderful addition for states that probably are ranked pretty low on their overall oral health um, access and status. So
Great, thank you. We're out of time. I'm sorry we didn't get to all of the questions, but here's Beth's email if you want to write
yeah,
to her and ask her yourself. But thank you, everybody.
all right. Thanks, Jean. Take care, everyone.